Welcome back to the Wellness Script podcast. I'm Lauren O'Reilly, a qualified pharmacist and your host for today. Leakage when you laugh, sneeze or run, heaviness, urgency, pain with sex, discomfort that you've just learned to live with. So many women are carrying symptoms like these that they think are just normal when actually they don't have to be. My guest today is Shalini Wiseman, chartered physiotherapist and clinical lead at Pelvic Health Programs, and she's here to tell us what pelvic health really is, what we should stop ignoring, and how to get help. By the end of this episode, I think you'll feel informed, reassured, and like you finally got permission and the language to take your pelvic health seriously. Shalini, you are very welcome to the Wellness Script podcast.
Thank you. Thank you for having me, Lauren.
Thank you for coming all the way from Cork today. It's such a pleasure to have you. I've been so looking forward to speaking about pelvic health with you because, as we were just saying off air, it's an area that even as a healthcare professional, I don't remember covering it in college at all. So what we don't know, we don't know.
Yes, true that. Yeah.
And so I suppose we'll get into what it is and how much of an impact it can have for people. But I suppose first of all, what drew you to this area of physio?
So, I had a very funny journey. So I was working in Bantry Hospital.
Okay.
So that was my first port of call in Ireland, and I came there as a basic grade physio, or a staff grade physio, and you do general everything. So it's like jack of all trades.
Yes.
So they needed a women's health physio. Some of the seniors were working in the community. They didn't want to dedicate the time for it. And then the remaining were men, male physios. They weren't going to go ahead and do women's health physio. So manager just turned around and said, you go do it. That's where it went on from there. So I went and did a postgrad in Bradford University.
Okay.
And it just tumbleweeded from there. And I started doing a lot of clinical work. Bantry was a great learning experience in many ways because there was no other person with experience in women's health. So I had to do a lot of reading, which set me on the path of getting into the habit of reading to learn things. And then I was introduced to two very senior physios in Cork. So Jean Dennehy was in Erinville and Mags MacDonald was in Bonds. And they helped me a lot in terms of getting my experience up and getting the services up in Bantry Hospital.
Okay.
So we started the women's health there, and then when the maternity hospital opened in the Cork, the Cork University Maternity Hospital, I moved from there.
Okay.
So and then it's been a journey there, and from there you had babies and went part-time, and then I went into one-day private clinic, and then I left CUMH and went completely into private clinic. So it's been a journey. It's been interesting.
Wow.
So from a very community service, so we were from a primary care service like in the community where you saw everything from stroke to continence.
Yes.
To coming completely into women's health, where you saw obstetrics, gynecology, urogynecology cases, oncology gynecology cases, and then taking that into private practice has been a journey. So
physiotherapy is always it's one that I always lean on in terms of recommendations to patients because it's just so there's so much that can be helped through physiotherapy. And so when you started, as they were looking for someone in women's health physio. Is that to say there was nobody covering it at the time?
So actually there wasn't anyone covering.
Wow.
So we had one senior physio who did antenatal classes, but there was no one doing gynecology.
Okay.
So we needed a physio to see incontinence and stuff. Now West Cork is very well catered for. They have two extremely good physios in West Cork services.
Yeah.
So during 2003, 2004, it's giving my age away, but yeah.
But that's relatively recent is what I'm thinking is that those services weren't available. Like you were thrown into the baptism of fire because you were the first one
starting the service.
There.
Yeah.
So and I suppose that's why even now people like you obviously are putting great information out online and in talks we were saying earlier. But really, like even from a pharmacy perspective, I only discovered pelvic floor physio and women's health physio through, I suppose, through social media and also through my own like journey and needing to go to a pelvic floor physio. So that's why I feel like it's,
and it's I do think Cork is very lucky because we've got great physios in Cork. So we have 6 very good women's health physios 6 to 7 women's health physios in the maternity hospital. We've got physios in the Bonds Hospital, and we've got a few in the private services. We've got physios in East Cork and West Cork as well who do women's health and pure, like you want people who do gynecology work, not just antenatal work. So because it's more, there's more injuries and rehab that needs to be done postnatally than antenatal. Antenatal is the happy zone. It's easier to deal with. You know? Yeah. But in Ireland, like I can speak for Munster, like Limerick, Tipperary, Wexford is not that well catered for. We still need more women's health physios in those counties. You know, so and definitely a lot more availability because a lot of those girls are traveling up to Cork to see one of us.
The accessibility is not there. So the first piece obviously is the awareness, being aware that it might be something that you need. And then the second piece is if you're going to be referred, that it's actually in your locality, like available to you.
Because you can't be managing babies and going and seeing a physio. And it's not just a one-off where you're given exercise and you go. Sometimes based on your issue, you might be seeing the physio for 6-7 sessions. And sometimes if you've had a bad birthing trauma, you might be seeing the physio on and off for nearly a year. So, you know,
and so for anybody who hasn't, like I hadn't heard of a women's health physio a couple of years ago. What is that? What do you cover? I know it's a long list, but
so we instead of saying women's health, we have turned it into pelvic health. So pelvic health comprises of urology cases, and obstetric cases. So when you talk about urogyne cases, that can be anyone from children to women. But you also have pelvic health for men. Now, I've not gone into that because I really want to stay in one lane. I don't want to mix the two because it's not like treating the same region. It's different and there's a lot more medical stuff that you need to know. So I've stuck with women's health. So when you talk about women's health, you're talking about anything to do with endometriosis, polycystic ovaries in young girls, sexual dysfunctions like dyspareunia. You can have antenatal cases. So you might be just looking at pelvic girdle pain. You might be talking about birthing classes, preparation for labor. Then you're looking at postnatal. Postnatal can be anything from incontinence to prolapse to obstetric-related anal sphincter injuries that you need to treat. You then might be looking at older women in perimenopause, menopause state. And again, they come with a lot of problems from worsening of incontinence that they've carried on from their births. They might, and again, then added changes and architectural changes because of perimenopause and menopause changes. So those kind of things you're looking at. So then again, in the older urogynecology cases, you're looking more at prolapses. Sometimes you can be looking at recurrent UTIs. Again, a lot of dyspareunia cases. So, and then we also look at oncology cases. So gyne-oncology, post-hysterectomies, anterior wall repairs, posterior wall repairs and stuff. We're seeing them for rehab after. So it's pretty diverse.
It is
very diverse. And then there are girls who also see pediatric cases, and then there are girls who do women's health and men's health.
This episode is sponsored by Elav Skincare. Elav is an Irish skincare brand whose sensitive skincare story started in 1934, so there's over 90 years of skincare expertise behind everything they do. It was founded in Ireland by the Gardner family apothecary, and 4 generations of the Gardner family have helped people with anything from minor irritation to sensitive and reactive skin types, which are conditions I come across all the time as a pharmacist, and something that I know so many of you are navigating too. Today, their award-winning skincare innovations are at the forefront of dermatology, free from sulfates, alcohol, perfume and artificial colours, ensuring that they leave in what's suitable for all skin types, which is why for years I've been happy to recommend their products to both my patients and my community alike. With eLav products, you give your skin what it needs and not what it doesn't. You can explore the full range at elavskincare.com and in retailers nationwide. And as a listener of the Wellness Script podcast, you can use the code WELLNESS for 20% off online. And it's important to know that they're available as well, for men as well. So there's so many different life stages that you touched on there, from young girls and adolescents right through to perimenopause, menopause. In terms of we were speaking off air, and this is how it came up for me, is that I went to a pelvic floor physiotherapist, and she could guess by the way that I was holding myself that I had done ballet and gymnastics and things like that. Talk to me about this, because I think it's so interesting what you told me.
A lot of girls who are in very high level sports, such as gymnastics and ballet, they come from a very old school Pilates approach of engaging the core all the time. The problem is they're actually sucking in their tummy and keeping their core real tight. No muscles should be constantly engaged. Like, all our muscles need to lengthen and relax, and then they need to contract. We don't go about holding up our biceps tight all the time. The problem with engaging your core all the time, and that's kind of like a learned habit with a lot of ballet people and gymnastic people, they end up putting so much of constant intra-abdominal pressure onto their pelvic floor that over time, their pelvic floor, to hold the pressure that's coming from the intra-abdominal area, they end up getting short and tight as well. So then those girls can come to you with issues of urgency, with urge incontinence, and sometimes even like issues with painful sex and stuff. So for them, it's a coordination issue. It's to do with breath. So learning how to let go of your breath, let go of your abdomen, learning how to breathe properly, and then learning how to lengthen and relax your pelvic floor is very, very important. The other thing that you'd find with a lot of them is actually they're all apical breathers. So they do all short, sharp breath. They're not diaphragmatic breathers.
Right up
so
in your
again,
chest.
it's all back to coordination, getting them to coordinate their breath and letting that abdomen relax a bit more so that they take the pressure off your pelvic floor, and learning to return the pelvic floor to a normal state helps. Now, this is not an issue just in ballet or gymnastic population. I've seen young girls coming to me from the GAA population of hurling and football. So the girls were 15, 16, and all of a sudden they're finding that they're having a bit of incontinence when they're leaking, or when they sneeze, or they laugh, or they go out for sleepovers with their friends, and they find they're actually nervous of going, because if anyone makes them laugh a lot, they end up leaking. The problem with a lot of those girls who are playing camogie and football is they are always doing short contracted exercises. These girls are still developing. All of them are playing high impact sports, so they do a lot of bracing to actually take the impact. And how do you brace? Tighten up your tummy. So they do a lot of bracing to take the impact, and their training involves a lot of sprinting and very high level weight training. But none of them are given any yoga based stretching exercises to do. And that's what I would tell a lot of the girls' mums, is that get the girls to do things like warrior ones, warrior twos, Cusack squats, child's poses as well in the training, so that you actually get stretching of the pelvic floors. Look at their breathing, get their breathing right. So if they're always doing apical breathing, which is very short, sharp chest breathing, so that basically, and holding in your tummy, and instead of being nice and relaxed and much more diaphragmatic or belly breathing, you actually need to retrain that. So that's a big, big thing. And like, while it's really good to do the high level weight training and stuff, you also have to do a little bit of lengthening. And what's happening with a lot of the young girls is that they're actually not stretching even their hips and their adductors and their hamstrings and calf muscles. They all end up using the massage guns. Now, that's really good. I'm not against it. I do think it's great for relief because it increases blood circulation, but you're not actively stretching your muscles to give length to it. So that's really, really important, that their rehab or their post-training involves certain amount of hip stretches and looks at breathing and relaxation and teaching the young girls to let go of their pelvic floor so that they bring length back into their pelvic floor instead of constantly be in a guarded, protected state. So that's a big, big thing. And it's increasing because I think this needs to be talked among the GAA clubs, that while they are training and they're doing a lot of impact-based bracing stuff. So someone's coming to you with a big stick.
Yes.
Yeah, your natural reflex
This
is
is
like,
why I didn't play.
yeah, you guard and you hold.
Yes.
And then they don't really know how to let go and lengthen and get the pelvic floor back down. As they get older, they end up having more pelvic floor issues. And you have to remember, the muscle has to stretch. All our muscles have to stretch.
Okay.
Our muscles don't remain in a short, tight state all the time. Our muscles have to be in a normal tone, nice, relaxed state. So, that's very important to teach from a young age.
What happens in the body when we stretch? Is there signal sent that we're...
So when you stretch, you basically end up stretching out your muscles fibers.
Okay.
And you're bringing it in the normal range of movement. So all our muscles have a range of movement. Yeah. So biceps is not always held short. It has to do this so I can actually reach over and get my glass of water. But it also needs to contract so I can scratch behind my ears and stuff. Yeah. So you have to do the normal movement. But if I'm always keeping it in this state and all of a sudden I want to actually need to do this, I'm not able to do the lengthening.
Yes.
So that's why stretching is important. But it's the norm is to maintain the normal range of movement. Every muscle in our body has a range of movement, and you have to go through that lengthening process to maintain that normal range of movement. Okay. So stretching is important to prevent stiffness, not just stiffness of the muscle, but stiffness of the joints, because the joints depend on the muscles lengthening to stretch the joints out as well.
Yeah. And that all extends beyond pelvic floor.
Exactly.
That applies to everybody.
Everything. Yeah, exactly.
So much of what I see in the pharmacy is chronic pain, frozen shoulder, sciatic pain, and like, I do think that a huge portion of what we see is also to do with sedentary, the way that we live.
Yeah.
Like, even if we're getting out to the gym for an hour, even, for the other 8, 9, 10 hours of the day, if we're sitting at our desk, I just think it's so
important that we actually do certain amount of just lengthen and move and get that movement and the fluidity in the body going.
Yes.
Exactly. And that's the same thing with the young girls. So whether it's ballerinas, whether it's gymnastics, again, they're coming, they really do engage their core to get through a certain amount of tasks of rotation and spinning and stuff. And that requires you to have a strong core, but at the same time, they need to be able to let go of it and bring it back to normal.
Yeah. So that should nearly be part of the training, right?
Exactly. Yeah.
We're not just training gymnasts to be, absolute machines or camogie players to be able to brace for the defense. These are developing girls.
And the problem you have with that is that's actually more injury prone.
Yes.
Because you lose the flexibility of your muscles, and each muscle should have a flexibility. So if all you do is shorten and tighten your muscle, you actually are making yourself more injury prone. So the ability to lengthen your muscle and bring normal tone to your muscle and get a coordination from a pelvic floor point of view, get a coordination between your breathing, your diaphragmatic movement, and your pelvic floor movement is very important.
Yeah.
So the diaphragm and the pelvic floor are very related, irrespective of age. Yeah.
Okay.
So if you look at a toddler breathe, they always have a Buddha belly, and you'll see that rise. They have the best breathing, and they see that rise and fall. Yeah. And as we get older, somewhere along the teens, we lose that, and that can be anything from anxiety.
Yes.
You could be getting bullied in school, or you've been taught to engage and you're told, pull your tummy in, stand up straight, pull your tummy in. But there is nothing known as a good posture, bad posture.
Yeah.
You're meant to sit in different postures to what suits you.
Yes.
You don't always need to be in a military stance. Yes, exactly.
Yeah, okay.
So
that sit up straight kind of mentality is not always serving.
Exactly. So your diaphragm, again, it's related. So when you're doing the Buddha or the belly breathing, what I call it, when you breathe in, your diaphragm descends down to allow for your lungs to expand and get air in. And as the diaphragm descends down, your pelvic floor also lengthens to allow for that movement. And then as you breathe out, your diaphragm moves up to push everything out of your lungs, and your pelvic floor recoils back up. So technically, as I'm talking, my pelvic floor should have a gentle movement like a jellyfish.
Okay.
And if that gentle movement is lost, then that flexibility and that recoilability is lost. And hence, then you end up with different dysfunctions from stress incontinence to urge incontinence to urgency, not making urgency with the bladder.
Yes.
And in some cases, it can get very stiff and tight over time. That can then lead to sexual dysfunctions with pain with sex and stuff too with time.
Yeah. So that's how then that manifests and presents to you after these years of engaging in different habits.
That's one of the reasons.
Okay.
One of the reasons that can cause pelvic floor dysfunctions.
Okay. And what are the other?
So other reasons could be children.
Yeah. Okay.
Yeah. Children, every pregnancy will have some impact to your pelvic floor.
Okay.
And every birth has a bigger impact. Vaginal births, unluckily, have more. I'm not advocating for a section, but vaginal births have a lot more impact on the pelvic floor.
Okay.
And then the length of your pushing, how your baby presents itself out on the way out. So whether it's an OP presentation, a sunny side up presentation, what they call it.
Right.
If you have forceps used, then you are much more higher likely to have damage to your pelvic floor compared to vacuum. If you've been pushing for too long, you can sometimes damage if you're pushing for having a very quick, fast birth, like within 2 minutes you're done. You can have damage to your pelvic floor. So there is factors that can affect your pelvic floor. The number of babies you've had will have a knock-on effect as you get older.
Okay.
Yeah, especially when you hit menopause.
Yes.
Because of hormonal changes. The architecture changes and all of a sudden that springy collagen is much more laxed and suddenly things are sitting a bit lower and you're then having issues. So, so pelvic floor ages and changes as we get through life and depending on what history we go through. So because of that, we do kind of want to look after our pelvic floor at each stage. So if you have an issue, address it.
Okay.
Because there is very good research that has shown that if you are complaining of incontinence at 3 months postpartum and you don't address it, the chances are you will carry that incontinence for nearly 20 years of your life.
Oh, wow.
Yeah.
Okay. And what does incontinence look like? Just so that
incontinence is, so there are two types. You have the bowel and the bladder. So if you're talking about bladder, incontinence is where you end up losing a bit of urine or a lot of urine, say when you sneeze, laugh, cough, walk. And sometimes with women, they might not leak with those things. They're perfectly intact, but they leak with impact-based activities such as running, jumping, skipping, jumping jacks, trampoline.
Yes.
Yeah. So that also is incontinence. So if they only say, I only leak when I go on the trampoline or if I go for a HIIT class, but I'm all right. Otherwise, there is something going on there. There is some sort of a coordination issue with your pelvic floor. Maybe your strength is not adequate to take the impact and you do need to get that looked at.
Yes.
Yeah. So that would be the urinary incontinence. Then you can have urgency with the bladder, what we would call overactive bladder.
Yes.
Or in some of the women, you can have sensory urgency where just the tap turning on, they feel they need to go and they can't hold on to it to get the loo on time. That's your bladder incontinence issues. Then they can come to you with symptoms like difficulty emptying your bladder, incomplete emptying of the bladder, post-void emptying, post-void dribbles. And again, those are actually structural issues that need to be looked at. And you just need to rule out any neurological issues as well.
Okay.
Yeah. Then you can have fecal incontinence issues post-birth. And that generally comes with very traumatic birth where you've had a 3rd or 4th degree tear, where you can't make it to the toilet on time. You're not able to defer your urge to go to the toilet. Sometimes you can have a bit of passive soiling issues and sometimes control of wind is poor. And that tends to be the Cinderella of pelvic floor dysfunctions. People rarely talk about it. And generally what I would find is that people are far more happy talking about bladder dysfunctions than actually any bowel dysfunctions till it gets to a point where they can't take it anymore.
Okay. So they're coming to you in a really bad way.
Yeah.
And this could be a good while after.
And I have had girls who have come to me with incontinence. Like they would be in their 40s, they're done with their babies, they're teenage kids. They will finish their treatment for their bladder and then they'll start talking about their bowel.
Oh, wow.
And I'm like, why didn't you tell me this before? I'd have saved you time. I'd have actually put all the treatment together and, we'd have targeted the two areas much better,
Yes.
and then I have to go back and do an anorectal review to see what's going on there. So while I've asked them a series of questions, they will say, no, I'm fine. And then they're like, oh, by the way, and you're like,
So
it really is a Cinderella of the pelvic floor dysfunctions.
There's shame around bowel incontinence then. Even with the pelvic floor physio. That would have a huge impact on, like, psychologically, just doing social activities and doing exercise.
Exactly. So they won't leave the house till they've opened their bowels.
Right.
Yeah. And they'll watch their diet and So if they know they've had cheese and wine the night before and they're going to have a very runny stool, they will make sure they're in the house till they're happy to get out.
Okay. Yeah. So that's a huge impact.
That is.
On how you live your life, on your work even, and on your on everything.
Yeah.
It's just so broad ranging, and I find that that it's just not something that we might think of. The way that I see it is, if somebody comes in, especially young women, for example, like that you would describe, who are doing sports and so on and so forth. I might see, or they might say, oh, I've had so many, this is my third course of antibiotics for a urinary tract infection. That's when I'm saying, you could benefit from pelvic floor physio for sure. That you should at least be examined, because it can't just be bacterial infection all the time.
What I would have found is that if you're having recurrent urinary tract infection from a pelvic floor point of view, one, put them on vaginal estrogen.
Okay.
Especially if they're in their 40s and they're getting recurrent UTIs, because that prevents architectural changes.
Okay.
Yeah.
Are they adaptations?
They're adaptations that are occurring. Yeah. The second thing you need to rule out is, are their pelvic floor tight? As you go through perimenopause, because the lack of estrogen, you end up with a lot of fibrous changes in the muscles. So your muscles tend to be a lot more tight and stiffer. Yeah. So that's why in perimenopause, the rise of frozen shoulder and tendon injuries a lot more. So if they are the same structure as your pelvic floor muscle, so if it can happen to your shoulder, why can't it happen to your pelvic floor? But because there is that stiffening and tightening of the muscles, and then it might not be emptying their bladder properly, plus microbiome changes that occurs in your vaginal area and in your bladder because of the low estrogen, all that combination can actually cause recurrent UTI. So while they might get long-term antibiotics, they might be getting vaginal estrogen, you need to rule out and see, do they have tight pelvic floor muscles as well?
Yes.
And physios do a lot of manual therapy inside for the pelvic floor muscles, and that does make a huge difference.
Okay.
The second thing that I would say is architectural change. Have they developed any kind of an anterior wall prolapse?
Oh, okay.
So what we would call a cystocele or an anterior wall prolapse. They might have never had that before, but because of perimenopause, the architecture the collagen's changing. So like how you end up getting jowls as you age.
Yeah.
To hold that up.
Yeah.
That anterior wall sits down a lot more after 3 babies than what it would have done when you were in your 30s post 3 babies, compared to when you're 48 post 3 babies. Yeah. So and there's perimenopausal changes, lack of hormones, lack of the collagen changes, things sit a lot more down. So if you are having a bit of a prolapse, a recurrent UTI can be also because of that. The two things from a pelvic health point of view, with recurrent prolapse, with recurrent UTI, apologies, you need to look at is whether there's tight pelvic floor muscle and whether there is a prolapse present.
And what is a prolapse?
So prolapse is an architectural descent.
Okay.
So there are different types of it. So you can have an anterior wall prolapse, or what we call a bladder prolapse, and its technical name is cystocele. You can have a uterine prolapse.
Okay.
Yeah, so the uterus is heading south, and then you can have a posterior wall prolapse or a rectum prolapse, where the rectum starts descending into the back wall of the vagina.
Okay.
Yeah, which is called a rectocele. Yeah.
Okay.
Then you can also have a rectal prolapse, which is a prolapse of the rectum in your anus, but that's very rare, and it's different from what most women who have birthed find. So vaginally, you will find these 3 prolapses, and they would be then graded from a 1st degree to a 4th degree, where 4th is basically out. So when you're coming to 3rd and 4th, you need to look at surgery. Generally, 3rd and 2nd you can manage with a pessary to try and hold it up.
Okay.
Yeah.
That's the ring.
That's the ring. Yeah.
Okay.
So depending on the type of prolapse you have. So if you have just an anterior wall prolapse, the ring will do you. But if you have an anterior wall and a uterine prolapse, you might be using a ring with a support or a dish with a support. So there are different types of prolapses you use.
Yes.
If you have a rectocele or the posterior wall prolapse, unluckily, there isn't that many good pessaries available. The cube pessary works, but because you have to take it in and out every day, the compliance, women get sick of it.
Yes, I can imagine.
Yeah. But like if you're looking at recurrent UTI, it is always the anterior vaginal wall prolapse that can contribute to the recurrent UTI as well.
One of the things I see all the time in the pharmacy is parents standing in the aisle trying to find something for a baby with a blocked nose or a toddler with a cough, and the options for the really little ones are surprisingly limited. So when something gentle and effective comes along, I think it's definitely worth knowing about. Otizan's range is something I genuinely recommend keeping in the family medicine cabinet year-round. From their baby nasal spray and the Fortos cough syrup, both suitable from 1 year old, to the nasal wash, which can be used from ages 6 and up, the whole range is natural and family friendly. From seasonal sniffles to coughs to ear care, it's a full family wellness range from Otizan, an Italian natural wellness brand that's been around for over 30 years. They are ear, nose and throat specialists that combine traditional herbal knowledge with modern research. And today their products are used and trusted in more than 30 countries around the world. And you'll find them in pharmacies and health stores nationwide. Okay, and if somebody's listening and, or even like from my own perspective, like I've had no kids yet, if I wanted to anticipate or get, I know we can't predict every kind of outcome that might happen to us when having children. Like how do we, are there things that we could do now that set us up well?
My mantra with young girls is you don't look after your pelvic floor after the baby. You don't look after it in your pregnancy. You get a checkup before you get pregnant. Yes. So you rule out any issue of tightness in coordination, weakness, and then you work on it. Yeah. And unluckily with life, a lot of us are kind of time bound. So by the time we're ready to have babies, we're in our 30s. Yeah. So I would say continue trying to get pregnant, but get your assessment done. Make sure that there is no coordination issue. There's no weakness. There's no tightness. Work on that while you're trying to get pregnant. When you're pregnant, enjoy that. Don't worry about that. If you need to see a physio, the physio you've seen before, you got pregnant, will advise you to come back. But at 34 to 35 weeks, you do need to start perineal massage. Antenatally. That's a must. So irrespective of whether you've had one baby or 10 babies, you should be doing your perineal massage at 35 weeks onwards.
So you should have seen a pelvic floor physio to guide you through that.
Exactly. Yeah. And that will make a difference to you. So again, it's a one session that you're looking for. You're not looking for follow-on sessions.
You just keep doing
that. And that will make a difference. If it's your first baby, if it's your first pregnancy, then I would recommend doing the perineal massage and using a thing called Aniball or Epino. These are little silicone devices which are like little balloons. And you basically put it up you, and you pump it up so that it kind of expands. Now you're not making it really big, so that you get a bit of a stretch effect, and you kind of know how to relax your pelvic floor around that. So when you're going through labor, you have practiced it, because we all have this assumption that we are going to naturally know what to do in labor, but a lot of times we don't, and we're expecting someone else to tell us while we're in the thick of it, which is very difficult to listen to. So learning how to relax your pelvic floor, and this is the only time you will be taught to relax your pelvic floor unless you need it clinically, otherwise in a later stage. So all this while you're taught how to strengthen your pelvic floor, but antenatally you'll be taught how to relax your pelvic floor. So you actually know how to relax your pelvic floor so that the uterus can push the baby out, because it's not your pelvic floor who pushes the baby out. It's your uterus and the baby and yourself who pushes the baby out.
So
your pelvic floor,
it just needs to be relaxed.
Exactly. So you learn how to lengthen and relax your pelvic floor. So two things, perineal massage and invest in the Anibol or the Epino. It doesn't matter. Both are pretty much the same product. It depends on what you want to buy. Do your research and see. For first-time mums. Second-time mums or any pregnancies after your first, you don't need the Anibol or Epino. Perineal massage is what you need to do. From 35 weeks. And then postpartum, normally they say get checked at 6 weeks postpartum. I am not very fond of the 6 weeks check. I think that should be done by the doctor, the consultant, to make sure the stitches and all are healed. I prefer a 10 to 12 weeks check. I want to see the woman when she's active, not when she's passive. I want her to start walking. I want her to see, can she do a small run? Can she do a little bit of a weight training session? And how does she feel after? Yeah. So I prefer an 8-week check than a 10-week check because I want to see how she is when she's actually active and how is the pelvic floor responding to loading. Whereas at 6 weeks, that woman's just got out from night shifts and feeding and just about established breastfeeding and if she wants, so like it's a lot for a woman to then me telling you have this and I want you to do this. I think around 8 to 10 weeks to 12 weeks is a good mark to look at postnatal rehab again. So you want to see how she's adapting now in normal kind of life. And most of the times the girls would have been given advice with regards to pelvic floor exercises in the wards, in the maternity wards, but teaching them, looking at them internally, seeing what's going on. Do they need a little bit of a silicone pessary to hold things up so that things will shrink better? That I think at 10 to 12 weeks makes a lot more difference. Then getting them to do a little bit of activities, see how they respond. If you're running, you're not going and doing a 5K run at 12 weeks. You're going to be looking at doing maybe a 1-minute run, 3-minute walk. How does that feel? Come back and report so that the physio knows what they need to work with. That makes a lot of sense. And even like that's so important to know, like that we can think about it in advance. But even if regardless of whether or not somebody wants to have children, I think that investing in learning about your pelvic floor is very important. So again, just because you each to their own, if you don't want to have kids, that's fine. But if you are nulliparous, but if you are complaining of any bit of incontinence or if you're complaining with pain with sex, you should get that addressed too. There is some sort of a coordination issue going on with your pelvic floor. It might be tight. It might not be firing properly. There's something not right there. It could be your breath. It could be how you engage your abdomen muscles over your pelvic floor to increase the pressure onto it. It needs to be addressed because that only will get worse as you age, especially when you start dropping in estrogen. So if there's something coming up there for you, you do want to get that addressed. And is that one of the reasons why maybe younger women would come to you is pain with sex? Or so I do get a fair number. So they my clinic is near UCC. So naturally. I get a lot of the girls text me going, I have uni at this time. Can I get an appointment at this time? I'm like, no problem. It's like, I do know when, and generally at 9 times out of 10, when they come to me, it's always to do with dyspareuria, which is pain with sex. And some of the girls actually have vaginismus. So when they start talking, they're like, I've just got sexually active. I'm finding it horribly difficult. And I'm like, were you able to wear a tampon before? Nope. And some of them are so very hypertonic that actually getting them to do physio might be too much for them. So I send them to the urogynecologist consultant for Botox. So they do Botox for the pelvic floor. That actually just takes the rigidity completely away. Obviously, it's a pity it's in an area which you can't show off. But like the Botox, but it works clinically very well. And then 10 weeks post Botox, they come back for physio. And then we start working on them. We get them to look at their breathing, look at stretching exercises. Some of the girls need dilators. And we go from that. And so the way in which they end up presenting to you is probably through those ways that we mentioned, with whether it was sports or whether it was a psychological. So and generally it's when they start getting sexually active
that they notice.
That they're actually not able for any sort of accommodation in their pelvic floors.
Okay.
Yeah.
They've just
Yeah.
been,
Yeah.
everything's
Hypertonic, exactly.
which means like really tightly squeezed, right?
Yeah. And they'll also complain, oh, I've always had very bad periods. I'd have take 4 or 5 days off school for periods. I've always had a lot of bleeding, So, and they might also be on a pill from the age of 15 or 16. So,
and then that muscular component wasn't necessarily considered. It might have been, I don't know, they just think you just have bad periods.
That's it.
Okay.
Exactly. And again, like, it's very difficult to even assess the pelvic floor when they're so young, because just the ethics of the whole thing, you have to kind of be 18, or you need to be sexually active. So it's, you can give them a lot of external things to do, which will help.
Yes.
But sometimes you do need a good internal assessment to know exactly what's going on.
Okay.
Yeah.
So if somebody's going to a pelvic floor physio, I'm sure it will depend what your presentation is, but is that what people can expect? Like what is the appointment like?
So appointment, I would say this. If you are going to a physio who is going to just check or talk to you and give you advice and say, I'll check you externally, it's not adequate.
Okay.
It's like going to a physio for knee, and person looks at your knee through your jeans. Okay. So it doesn't really help.
Yes.
Whereas there is a lot more a physio can pick up with an internal assessment.
Okay.
So when we do an internal assessment, we do it with consent. We explain it to the patient exactly what's going to happen, what we're going to do. We're going to then look at internal assessment. We look at muscle tone. So there are superficial pelvic floor muscles and deep pelvic floor muscles. It's there on your right side and your left side.
Okay.
So like your right quadriceps and your left quadriceps and your right, same way your pelvic floors have 2 groups of muscles on either side.
Yes.
So we look at the 2 right and your left side of the muscles.
Okay.
We look and get you to bear down, see if there's any prolapse coming down, especially if you've had any births. Sometimes with prolapses, we might even assess you in standing, because that gives a better presentation of how low, because none of us spend our life lying down. It's more standing. So to see how low the prolapse is, which gives you a far better idea of how it's impacting the person as well. And then we look at muscle power. So we will look at how you're able to pull up your back passage and pull up your front. So how you're facilitating your pelvic floor. Are you doing any trick movements with your thighs, your bums, pulling in your tummy, holding your breath?
Okay.
So if that's there, we teach you how to correct that properly. And then we'll grade your muscle power from 0 to 5. So all your muscles in your body are graded from 0 to 5. So if you look at my biceps, if I'm able to bend my biceps fully, that's a good 4 or 5.
Okay.
If I'm able to do it with weights, that's a good 5.
Okay.
If I'm only able to bring it halfway up here, so if my elbow is at 90 degrees, that's a 3.
Okay.
If I'm barely getting to a 90 degrees of my elbow, that's a 2. And if nothing's happening, that's a 0 or 1. So if you're coming, so same way with the pelvic floor, we see how the muscles are kicking in.
Yes.
We look at the right and the left side, and they both have to come together and give you a central and upward lift.
Yes.
And if there's any deficit, we look at seeing whether you need some sort of an internal device to build up the muscles. So especially if you're 0 or 1, it's nothing happening. You can keep trying to do pelvic floor exercise and it'll make no difference.
Okay.
Yeah. But if you're a good 2+ to 3, then we give you tricks and teach you exercise, and we go from there. So like this is one of the things I would say with a lot of the girls is like there's a lot of online programs. For pelvic floor rehab. And a lot of our postnatal women do that, and they're excellent. There's nothing wrong with them.
Okay.
But get one internal assessment done. That one internal assessment is it will help you in your rehab far better than doing just a 12-week online program.
Yes.
It's extremely, it's a very sophisticated way of looking at a problem than just looking at it from the outside and doing a series of exercises for 12 weeks and nothing's happening.
Yes.
Yeah?
Yes.
So like my advice to women is do your pelvic floor exercises for 4 weeks. If it ain't making a difference, go and see a pelvic floor physio.
Yeah. No, that's so helpful, because I think like I had painful periods, but like no real reason for, like, as in I was just referred, okay, maybe go see a women's health physio.
Yeah.
Like I'd be doubled over, and even without periods, I'd be when I was stressed, I was doubled over. Like
Yeah.
I had to, I remember, sit on the floor during my leaving cert because I had so much
Oh,
pain.
wow.
And even like you get pain in the like back passage and everything just
Oh.
from so much clenching.
Yeah, and that's
Yeah.
a pelvic. The back
Yeah.
passage pain
Yeah.
is 100%
Yeah.
hypertonic pelvic flow.
Exactly.
Yeah.
And I wouldn't have
Yeah.
known that. And I think it also would have been helpful to know what to expect at a pelvic floor physio appointment. I had no idea there was an internal exam. I was like okay with it and everything, and it was really well explained to me. But it would have been nice to anticipate and know that that's part of it as well.
Yeah.
And like I was saying to you earlier, she did the deep belly breathing with me, the Buddha breathing. And she said, okay, exhale now. And I exhale. I said, okay, I've exhaled. She's like, no, you haven't. Exhale. And I realized then when she finally got me to properly exhale, I don't remember. Probably I was a child when I last did a proper exhale.
You know what? Sometimes that might be all you require to do before you go to any internal work. That's all you might do as therapy for a while to get your breathing right. And sometimes it's a gift from God if the person gets it right, because for all their life they have held their breath and done it wrong way. And to get that whole thing synchronized again is very, very difficult. So this is why I always think postpartum. Antenatal, the online programs are excellent, but get at least one review done to see what's going on.
That was so helpful, because if I had been doing that by myself, you know, just from an online program, I would have accepted a certain level of exhale as being, okay, I'm relaxed.
That's your exhale,
Until she said, no, you're going to have to go again. Until I got there, I didn't actually know what it meant to relax my pelvic floor. And it was a huge learning. And now I'm always aware of it when I'm driving, when, you know, just to relax.
Relax your pelvic floor.
Like even, and you said about like children. Now I have a little niece, and whenever I look at her, like her belly is so relaxed. I'm just like, it's so funny that we learn these habits where we like, we're born as children, we're babies and we're relaxed. We learn these habits to, as you said, whether it's bullying in school or whether it's a negative experience, there's so much emotional
tied to that area. Exactly.
So it must be kind of emotional in the room with you then.
It depends on, like, you have to kind of learn a bit of trauma-based treatment. So like you will need to look at certain cases which have very terrible history. So there's and sometimes then any internal work is not appropriate at all. So you're looking more at stuff that you can do with them in terms of getting them to relax a bit more. It might be just more relaxation based exercises and stretches and stuff, or you're teaching them to treat themselves with dilators. So like you do get certain cases which can be trauma based, and it can be anything from a bad birthing experience to childhood shame to, and sometimes sexual abuse cases. So you do need to be aware that you are going to see cases that can be a bit more traumatic and emotionally loaded.
Yeah, and I think for all of us, there's something in that, like that, even if we don't particularly have any identifiable issues as such with our pelvic floor, that becoming aware of it. You know, like are there things that might be applicable to everybody that we could do? Like yoga, you mentioned, is really stretching.
So I mean, for nulliparous women and young women, they don't really need to focus on their pelvic floor too much. So I like how you do strength and conditioning for your body. You don't really need to do strength and conditioning for your pelvic floor. But if you are finding that once in a while you end up having a big laugh and you end up leaking a bit, or if you are leaking with sneezing or coughing, or if you're going and playing tag rugby and you end up leaking, then don't push that under the carpet. Get that addressed. Do your pelvic floor exercises, see how it feels, but don't overdo it. Because if you overdo it, you could end up going the other way around, where you can tighten the muscle as well. So for young girls, to be honest, they don't really need to get too focused, like how you would say you need to strengthen your back muscles and your arms and all that. No, you don't need that. It works. It's only when it starts giving you a little bit of a hiccup, you need to start worrying about it.
And then if we're active, just finding that balance
between
the intensity of
Yeah.
training and then the
Yeah.
stretch and the
Stretching and
release.
stuff. Exactly. And,
Okay.
and focusing on your breathing and stuff will make a difference.
Okay.
Yeah. And again, if you are training a lot and if you suddenly find dyspareuria coming in where sex is painful, then that needs to be addressed.
Okay.
Because that's definitely due to some sort of a tightness of the pelvic floor.
And it can be corrected.
Oh, yes, it can. Yeah. There are many. Sometimes you might need a combination of physio and counseling.
Okay.
And psychosexual counseling. Sometimes you might need to go and see one of the consultants for Botox for the pelvic floor. And then you're coming back into the realms of physiotherapy and counseling. So it might be multidisciplinary. It might not be straightforward, just physiotherapy.
But I think that's important because there's different avenues and different routes that people go. You're not confined to this is something you're going to have to deal with for the rest of your life.
And like physios, generally, I find the girls who have worked in this area for a while, they're quite good at figuring out pretty much in the first session that actually I'm not going to be the only one this lady needs.
Okay.
She needs to go and see a counselor, and we have a list of counselors and stuff we can give them and advise them to go and see. And pretty much in the first 2 sessions, I kind of know, okay, physio is not going to get any far with her. She actually needs to go and see go for Botox, or,
Okay.
Yeah.
Okay.
Yeah.
So from what we've covered so far, there's the 2 sides with women's. Well, from what I'm gathering, there's the 2 sides. There's the hypertonic where everything is clenched up tight, and then there's the prolapse side where we need to strengthen things back up again.
Yes. And look at structural support.
Yes.
Yeah.
Okay.
Yeah.
And what does structural support look like? That's
the pessaries and stuff. Yeah. And like it's a big misconception that people think pessaries are only worn if you're old.
Yeah.
That's a really wrong misconception. There are some girls who will wear pessaries just like a ring with a knob, just for sports, because they're actually not incontinent, but when they're doing CrossFit and that's what they want to do.
Yes.
Yeah. Their architecture has changed because they've had babies. They have good pelvic floor muscle, but their bladder neck is that little bit lower. So instead of it sitting this way, it's starting to angle down a lot more. So when you're doing that really high impact, where you're going from burpees to box jumps to kipping, they are going to leak. And that structural support that you would have had in your 20s after birth has gone away. So those girls might wear a ring with a knob or just a ring just to get through that exercise time.
Okay.
I have a lady who is a farmer.
Okay.
And come February, she'll come and see me. She gets a ring.
Okay.
She pops that in just for Feb during the calving season.
Okay, very good. And that's what...
And that gets her through the calving season.
Yes.
So like and there's another lady I have who's a vet, and she has sheep. And whenever she has sheep, she'll text me going, "Oh, I think my ring has expired. I forgot it in the cabinet. Can I just collect a new one?" And I leave it in the post for her, and she collects it and goes. And she just wears it when the sheep are getting birth because she's up some mountain birthing the sheep, and she's happy out.
And it's an intensity of work.
And then other times, then she doesn't need it.
Okay.
Yeah.
So
just a little bit of support. It's almost like wearing a sports bra.
Yeah.
To give you that little bit of support. So I do think the general population need to get it out of their head that pessaries are for all women. You're old, your granny's age before you wear a pessary. No, you can wear it at any age because the structural support is gone. You could be someone who's doing high rocks crowd. Yeah. You get loads of them coming. I also get mad women who are doing ultra marathons. They're running up mountains for days, and I'm like just tired listening to them. I'm like, dear God, how long are you running? Those girls need some sort of a support structure. If you have hypermobility, and a lot of the athletic population actually have a bit of hypermobility as well, they need some sort of a support structure to get them through for that high level activity that they're doing.
And is that only because they've had children, or it could be otherwise?
Hypermobility could be otherwise as well. So, yeah. Okay. So I wouldn't write off pessary as just something that you have to be of a certain age group. Otherwise, I'm considered old.
And it also, like that, what that tells me is that it's not just that, oh, you need to do more exercise. Actually, you might need a structural support.
That's it.
Yeah.
That's exactly it.
Okay.
Yeah. So like the way I'd say is our bladder neck. Yeah. So our bladder neck, when we sneeze, cough or laugh, it sits just under your pubic bone. Yeah. And your pelvic floor should come and close the bladder neck up against the pubic bone.
Yeah.
And that pelvic floor should do it without you knowing it.
Okay.
Yeah, it does it on its own.
Yes.
Yeah. The weaker it gets,
Mhm.
then the lesser it's able to do it. And that's where pelvic floor physio is useful, because we build up strength and it starts coming back. The muscles start working again.
Okay.
But what do you do if it's your second or third pregnancy and that bladder neck is sitting lower and lower off, and that lift of the pelvic floor, however strong, is not adequate to get to close it behind the pubic bone?
Yes. So that pessary is actually lifting the
bladder neck.
Okay.
Exactly.
Wow.
So if you're going and running for 60 minutes and you're doing a 10K run and your bladder neck is basically doing this, it's bouncing up and down.
Yes.
You might need that little support to get you through the race.
But
And you get the lovely silicone ones. They're nice and soft. They're easy to pop in and out. Once you get the sizing right, you give the nice silicone one to the women. They're able to manage themselves done. And they don't use it permanently because they don't have a prolapse as such.
Okay.
But they use it for the activities they require, be it an ultra marathon or birthing a calf or calfing a cow. Whatever you call it.
Yeah. That's great though, because it means that it's not like, okay, I have this issue with incontinence occasionally.
Yeah.
I can't do that thing anymore. You can do that thing.
Exactly. There's ways and means around it.
Yeah.
You know?
You just need that support.
Yeah.
Structurally. And then exercises maybe go with that as well.
Yes, absolutely. Okay. Yeah. You do have to exercise because the reality is our hormones, estrogen starts dropping around 38. Okay. By 45, we're kind of considered perimenopause. Yeah. Every year, we lose 1% muscle mass because of the drop in estrogen. It's also a lot more difficult to build muscle mass because of the lack of estrogen. So you do have to do pelvic floor exercises.
Yes.
Especially once you hit around 35-ish.
Okay.
Yeah?
Yes.
Yeah. And if you've had kids, doesn't matter. You could have had a baby at 18 or you could have had a baby at 42. It's a must.
Okay.
Yeah.
Hey, if you're loving this episode, do me a favor and click subscribe. It helps the podcast grow and helps me to keep bringing you conversations like this one. Back to the episode. And now that we have more awareness of the perimenopause, menopause, and the prescribing of hormone replacement therapy, do you think that will help with what's presenting in clinic for?
Oh, absolutely. Absolutely. Because that architectural change, especially with the use of vaginal estrogen, you prevent that architectural change because of the lack of estrogen. Okay. So as you age, the way I'd say is when we are younger, our urethra is like a plastic straw. It's a lot more firm.
Okay.
And then you have mucosal tissue and collagen, which scaffolds the bladder neck. Okay. But as you age, that mucosal tissue thins. Okay. The collagen would have been nicely bound, starts getting more saggy. Okay. So that urethra, bladder neck, which is like a plastic straw, starts turning into a paper straw. Oh. It's a little bit more bendy, starts getting a little bit more kink. And that's where you're not getting that complete nice closure that you require. So when you're using vaginal estrogen, it plumps up that mucosal tissue. So it actually helps scaffold the area up better. Wow. Whereas if you're not getting the vaginal estrogen, that it's not plumping up your mucosal tissue. And if you get that in your 60s, if you're first time using vaginal estrogen in your life in your 60s, the chances are the architectural changes is quite severe that you're not going to actually be able to reverse it much. Okay. Yeah. So really most women should be on even if you don't want to be on systemic estrogen, so you don't want to use your gels and patches and all that, vaginal estrogen you should be on if medically you're all right. From cancer point of view and stuff. You should be looking at that. Because the vaginal estrogen is there's such a low amount absorbed systemically into the body. Yes, 0.8%. And you're only putting about 1 gram, so it's 1 mg. So it's not really much. And what I would say with a lot, and I when I talk to GPs, I always say this is like majority of the time GPs prescribe vaginal estrogen when a woman comes to you with dryness, discomfort with sex, lack of lubrication, or recurrent UTI. But they don't consider that if you have a 42-year-old woman coming to you with prolapse or someone coming to you with urgent continence or urinary incontinence. Okay. So you send them straight for physio. Yes. But a little bit of estrogen might actually help prevent that further architectural degeneration that physios can't change.
Yes.
We can only strengthen, we can get the muscles to work together, but we can't change mucosa around the area.
Okay.
Yeah.
So vaginal estrogen is relevant for perimenopausal, menopausal women, but also for those populations as well.
Yeah.
Is it ever relevant for younger women?
No, not
Only
really.
for
Only for 40, 43, 45 onwards.
Yes.
Yeah.
Okay. No, because that's so helpful. You might think, like, I suppose the way that I would have thought about it when we were learning about it in college was that this is helpful. Yeah, it came up with, when the mucosa is dry and the urinary tract infections. But even thinking about the structural changes is powerful, because maybe some women are not really bothered. Maybe it's not presenting as urinary tract infections or as dryness or discomfort, but actually it's still happening.
It's still happening.
And the structural changes are,
and that's why I think in UK you can get estrogen, vaginal estrogen over the counter, whereas here we still need to go get a GP prescription, and then now we get it free, which is great.
Thank you. Yeah,
that's a really good initiative done. But I do think if we can get Viagra over the counter.
Yeah, we can get Viagra. Yeah, exactly.
Why can't we get this?
I know. Yeah, definitely.
Like so many times I'm like, maybe we should try that. And then I'm like, you need to go to your GP. So then it's another 2-3 weeks, maybe a month before they approach the GP and then get that again, because women are always busy. They're always time poor.
Yes,
so,
exactly.
Yeah.
And if you were to address any myths, like, are there myths that women come in with you to the clinic with that you find you're constantly addressing, or
yes, myths. That's a good question, actually. So from a pelvic health point of view, what are the myths? Yes,
Kegels is something that I see coming up a lot.
Doing pelvic floor exercise will sort me out. Not necessary. That doing pelvic floor exercise is important for everyone. Not necessarily.
Okay.
Not if you are someone who has tight pelvic floors, doing Kegels will make you worse. For you, actually lengthening and breathing might be the only thing you require. That using vaginal estrogen will cause me cancer, which how much ever we tell them it won't, they don't listen to that. And like, we need to kind of say, look, unless it's affecting any other medical condition, this is perfectly safe. So those would be the little myths that you'd come with. I think more than myths, the women I find are very open-minded. It's the more phobia. I find that there are certain conditions they will not tell you till the very end, till they're very comfortable with you.
Like the bowel incontinence.
Yeah. This is the thing that I find more than any myths.
Okay.
That it's always, and you're like going, I asked you the question about in 3 sessions and you never said it, and you waited till you finished about 6-7 sessions. And at the time of discharge, you turn around and go, which is not a bad thing, because you better address it now than 10 years down the line.
Exactly.
But like, I think if that little phobia went away, but even like addressing pain with sex, women take it so personally that something's wrong with them.
Yes. Yeah.
Like that again is addressed so much more later. The only thing is, if someone has dyspareunia, it caused you to tight pelvic floor muscles. When you do an internal, you pretty much know it. So you're able to pick on that a lot quicker than bowel issues.
Yes. I think that pain with sex for women piece has been so normalized in like pop culture, and like, maybe especially for the first time, like that it's supposed to hurt or something like that. Like maybe that's kind of damaging as well.
So any heterosexual sexual encounter should not be painful unless you want it to be. Like if that's where you go, that's where you go. But a normal heterosexual encounter should always be very pleasurable and should not cause any discomfort or pain.
Right.
And there, at some stage, like foreplay is different at different times. Sometimes you are in for a quickie and you just want to get it done because there's another 10 things on your list to do. So again, the use of lubricants is vital. So one of the things I would tell the women is, after a certain age, once you hit around 50, using a lubricant makes a lot of difference. If you have a history of dyspareuria, using a lubricant makes a lot of difference, and not your general KY gel or Durex. You want to get a good quality lubricant.
Okay.
So you want to use like Yes organic one, which is oil-based or water-based.
Okay.
So if you're not using a condom, the oil-based is good. If you're using a condom, using the water-based is good. Yeah.
Okay.
Yeah.
These are the things that we need to know,
Yes.
Shalini.
Yeah,
you
yeah,
know,
yeah,
like because it's like you're just expected to know all
No,
of this.
exactly. So, because again, like you might be using the Vagifem, but you might still not be getting enough lubrication. And that has to do with the whole arousal and sexual function. That's complete different cycle that occurs. And unluckily, not all of us go into that cycle at with every sexual encounter. So then you need to kind of make adaptations accordingly and use a lubricant instead.
Help ourselves.
Help ourselves. Exactly. Yeah.
Well, I think that we've covered so much,
Yes,
Shalini, and I'm so grateful that you came in to speak to me and to share this with everyone today, because like it's just an area that even as a healthcare professional we didn't get the full coverage of, you know, and to be able to even know what we don't know, which is to know that, okay, I need a pelvic floor physio, if even that's the thing that people can take away.
And what I would like, and I really, and I've talked to a few other physios, women's health physios, and what they also would like is if they could get an opportunity in the area they work in, say whether it's in Cork or Limerick or Tipperary, that if there was a doctor's event, if they got 10 to 15 minutes in a GP's event where they could stand up and actually say, this is what we do, this is what we can help with, to educate. Yeah.
Yes.
And also give a bit of public awareness. I think a lot of us would be very happy.
Definitely. Even in the School of Pharmacy, like we would have done it. I come across the issues that it's relevant for so often. So it would have been really beneficial for that too. So how can people find you if they would love to?
Okay, I do have a bit of a waiting list, and we have very, very good physios in Cork.
Okay.
So I'm not the only private physio. There are a fair amount of us there. So I always don't go, I am the only one there. You know,
it's great.
It's like back of beyond. There's no one else there. You have to see me and wait on the waiting list.
No.
Generally, it's because I'm a small private practitioner, generally most people message me or text me on my mobile number, and I get back to them. I have a bit of a waiting list. I have about a 2-month waiting list currently. So, but I also prioritize patients. So I will always say, what do you need to be seen for? It helps me prioritize better. So if someone's like postnatal prolapse pain, I'm bringing them in much quicker. I am looking for cancellation. If you're kind of like, I have a bit of incontinence for the last 5 years, I'm like, okay, you could wait. Another 2 months wouldn't make any difference to you. Yeah.
Yes.
So I do prioritize. But there is you can get referred in by your GP into the urogynecology team in CUMH, and the girls will see you. There are 6 girls there. There are 3 women's health physios in Bonds in Cork, and then there's loads of private physios as well. North Cork has a primary care physio in women's health, and so does West Cork. West Cork has 2.
Okay, I'm going to put links in the...
Yes, and if you are looking at different counties, if you go on to the ISCP website, which is the Irish Society of Chartered Physiotherapists, and you look at, I think it's called My Physio on top of my head. If you look at that, it's kind of like Find Your Physio.
Yes.
And you can look at their directory of physios around different counties. It's very well done up, and it literally tells you what they do. So because you'll have some physios who might just do antenatal, and then you have physios who just do urogyny or men's health. So you'll know in which county you can get what.
Excellent. I'm going to put that below because I think it's really helpful to know where to start. If any of the things that we were talking about.
So the ISCP website is pretty good in terms of having a directory of physios in different counties.
I'm going to link your...
Dublin's very good.
Yes.
Dublin is extremely well catered for and excellent physios again.
Good.
Yeah.
Okay. I'm going to link your Instagram as well because you put out such valuable information, which you know everyone can consume. So thank you so much for joining us, Shalini. It was an absolute pleasure.
Thank you.
Thank you so much for listening to the Wellness Script podcast. I hope that if you've listened this far that you really enjoyed today's conversation. And I hope that you subscribe or follow wherever you get your podcasts so that you never miss another episode. It really helps the show to grow and make sure that we can continue to have these fabulous conversations about your health and wellness. And don't forget that you can download your free episode guide at wellnessscriptpod.com, where we've pulled together the key takeaways, practical tips, and important points from today's conversation, so that you can come back to them whenever you need. Until next time, take care of yourself, and I'll see you in the next episode.